Okay. So those guys have set me up nicely. I have nothing to disclose relevant. So we've already kind of gone through this for the last two talks, but there are a lot of causes of pain in the butt. For this particular talk, I'm going to focus on the first three, piriformis syndrome, ischiofemoral impingement, and hamstring pathology. We need to keep in mind that SI joint and lumbar spine can certainly be involved, as we just talked about. And I'll also always make note of the fact that the hip joint can actually refer to the posterior aspect of the hip while it's not common. We do see that happen, and so that differential diagnosis piece is really key. So we've already discussed this, how there's so many sources of posterior buttock pain, and it's really important to understand the anatomy and how to differentiate between these, and Rob and Dave did a nice job of walking us through that. So I'm going to get into a little bit more specifics on kind of what we like to try for treatment, and then when do I kind of throw in the towel and say, hey, it's time to talk to our surgeon partners. So obviously palpation can tell us a lot about the location of pain and symptomology, and we can really reproduce localized symptoms and even sometimes some of the radicular symptoms that travel down the posterior thigh with these patients. Specific to piriformis syndrome, the guys went through several different special tests, but simply the active piriformis test and the seated piriformis test, again with a palpation-based exam, making sure we're localizing the location of pain with these patients. And then you have to realize that piriformis syndrome can be primary or secondary, and to steal a line from Dr. Bird that he'll always use in these talks when he talks about posterior hip pain is that piriformis syndrome is both equally overdiagnosed and underdiagnosed problem. So a lot of times there can be coexisting lumbar, SI, or even hip pathology that's maybe a driver of dysfunction of the musculature that's causing what I would label as more of a secondary piriformis syndrome. There could be some pelvic floor involvement that may be driving some, again, compensation through the musculature of the posterior hip, again, compensating more of a secondary. And how can we sort this out? And in our office, one of the benefits we have is we have diagnostic ultrasound and someone who is probably the most experienced person in the world at doing image-guided, ultrasound-guided injections. So we'll see if this will play here. There we go. So just under ultrasound, I don't think this laser works, and that doesn't project very well up there, but you can see kind of a dark triangular structure through the middle showing the piriformis muscle. And we can inject under ultrasound to know exactly where we're getting medication. And we can do this both from a diagnostic perspective or from a treatment-based perspective. So when we look at conservative treatment options with piriformis syndrome, again, whether it's secondary or primary piriformis syndrome, we can start with an injection. Sometimes we'll do this with a corticosteroid, and when we do that, we also put some anesthetic in there. So if we put anesthetic in that localized region, the patient immediately has resolution of all of their symptoms. They have no remaining symptoms in the posterior buttock or thigh. Then that gives us a really strong indication that this is the actual location of not only the pain, but also the issue. And then with that steroid involvement, we can calm down any sort of inflammation, irritation around the nerve. We can proceed with our physical therapy interventions, which a lot of times includes a lot of manual therapy. I found dry needling to be incredibly beneficial in this patient population. It can help you both diagnostically and from a treatment perspective. So if we're able to stick a needle directly in a trigger point of a muscle and reproduce their pain, then that again confirms some of my suspicions. I use a lot of modalities in these patients, particularly things like shockwave, focused shockwave, and laser in our clinic. Again, as both Rob and Dave mentioned, we do stretching and nerve glides to keep that neural flossing going. And then again, strengthening the hip and core musculature. So we need to support everything around this region so that the piriformis is not overactive or compensating for other dysfunction. And then again, I think it's important to note that the pelvic floor can definitely be involved. And so an appropriate evaluation and treatment for that is necessary. When there is failed conservative management, these patients who are not able to get better with all of the things I just discussed, surgical treatment for decompression of the nerve can be quite successful. However, I would note that endoscopic release is significantly preferred over an open release. Obviously, a lot less scar tissue that can then form down around that area. When we rehab these folks, usually a very quick progression, get them moving very quickly, don't let any scar tissue form around the area, and they tend to do quite well. Again, it's important that we've diagnosed them correctly and truly failed conservative management, and these are very appropriate patients. Ischiofemoral impingement, again, begins with correctly identifying the cause of the problem. We can utilize injection of the quadratus femoris to solidify the diagnosis and also give us some temporary relief of symptoms, which can, again, help us from a therapy perspective. I'm going to make note of something that we have kind of we call it squishy versus bony in Nashville hip. Very technical terms here. But basically what we tend to see is two different types of ischiofemoral impingement that occur in our patients. And this is where the use of musculoskeletal ultrasound can be quite beneficial. So I'll show you a couple of videos here of these. So this is, and I'm sorry that this isn't projecting super well, but we have an asymptomatic left side. And basically what we see is we passively rotate it's kind of a active assist range of motion. So they're prone on the table. We're using the ultrasound and passively moving them through internal and external rotation. In a normal hip, you can see the musculature kind of contract normally between the bones. But when you look at it in a dysfunctional bony anatomy for ischiofemoral impingement, on this other side, you can kind of see the bones banging into each other as they move through that rotational movement. So we can see actual bony contact, and that's what we would identify in our eyes as a true bony impingement, where that lesser troch is banging in to the bone. However, on the flip side of that, we have what we call squishy. And really, this is a dysfunction of the quadratus femoris in that space, so in that ischiofemoral space. And what we see, again, you have your normal side here, the asymptomatic side, but on the squishy, which, can you play that one more time for me? The video on the right? Maybe? Essentially, what we'll see is as it goes through that motion, instead of contracting nicely where you see that kind of come together but without the banging of the bones, you actually see the muscle kind of bubble up out of that space, and then they're getting that kind of impingement from a lack of good muscular contraction. So when we see that and we're able to identify that in our office, that changes how we treat these patients. So I'll focus very strongly in that squishy patient on the posterior hip and the activation and strengthening of the deep rotator.
Okay, so just kind of my quick try and fire.
Oh, sorry, that should have been muted. My quick down and dirty assessment of the squishy,
put this on the inside.
The inability to contract the deep rotator.
Good.
So we'll just do a palpation-based test. Ask them to basically create an external rotation force,
Squeeze.
and I'm palpating that they're actually getting contraction in that lower buttock region. And I'm watching for any compensations, and you'll see me kind of cue Casey.
Now do it where you're overcompensating with your glute, where everything squeezes.
You'll see big muscular contraction of the gluteal muscles, and even some of the lumbar spine, or you'll see the hamstring kick in. So these are compensations that you'll typically see when people aren't able to do this. Once I identify that, then we can use this palpation-based activation, and then we'll progress them through various exercises. This is a series of exercises that Amir uses with John O'Donnell in Australia, and we have several variations of these progressions that we'll utilize in our clinic to try and progress them and give them more dynamic stability and control. With regards to the bony ischiofemoral impingement, Rob and Dave both kind of alluded to the fact that we have to make modifications to their gait or their training habits, their activity modifications, and kind of reevaluate. And unfortunately, at certain times in these particular patients, when there is an actual bony structure that's creating that compression on the nerve, a surgical endoscopic decompression of the lesser trochanter can be successful, and that's when I would refer them back to the surgeon. And then lastly, proximal hamstring pathology. This can be chronic and or a gradual onset of pain in that posterior hip region. They may remember an old injury that they described from months or years ago. Pain with sitting, or it hurts right on the bone, as they'll describe. Sometimes there'll be the nerve symptoms, but sometimes absent of any sort of neural symptoms down the leg. Oftentimes these individuals, at least the ones that I tend to see, will remain active. They'll still be runners, but that pain with running is getting progressively worse. And it can also coexist or be secondary to other diagnoses. I see this quite a bit with chronic abductor pathology, where the hamstrings are kind of picking up the slack for the lack of gluteal strength, and or joint pathology. So in our office, what we found non-surgical options to work quite well. Again, the role of injections, and I put a question on the role of biologics. I think that's definitely a growing area that we'll see more and more of. Modalities to stimulate tissue healing. Again, focused shockwave, quite commonly used in our clinic with good success. Dry needling, laser, and then exercise progressions that must train in different positions. So isometrics to start, and then working into shortened state training, and then lengthened state as described by Tim Tyler and his group. And then when these cases, unfortunately, are not able to recover with our conservative management, then certainly this would be a good time to refer to our surgical partners. And I think when they truly have failed conservative management and been diagnosed correctly, that they actually can do quite well, but I think their expectations have to be realistic. Acute versus chronic tendinopathy, the acute tears tend to do better if you look at some of the systematic reviews and the studies that have been done. Also, runners don't tend to have as much success. The statistics would say that most of them, or about 50% of them, don't get back to running at the same level as their pre-injury. And greater satisfaction was noted in patients who are actually over the age of 50 as compared to under. But again, can be quite successful. Acute repairs tend to return to sport quicker or physical activity quicker. So in conclusion, again, diagnosis is going to be the most important thing here. So an appropriate diagnosis, understanding of the anatomy, and a comprehensive history and physical exam. Diagnostic injections under ultrasound can be incredibly helpful in teasing out these patients and figuring out exactly what we're dealing with, and also giving you better time to deal with your conservative management. And again, when we aren't able to manage them conservatively, we do find that these cases can be considered for surgical release of the sciatic nerve in the case of ischiofemoral impingement or piriformis syndrome, or with these proximal hamstring pathologies, again, do quite well when conservative measures fail. Thank you.